Patricia Scow. Pat is the Executive Director of the Illinois Critical Access Hospital Network, or ICAN, the first statewide critical access hospital network established in 2003, comprised of 57 critical access hospitals and rural hospitals, which is providing a number of hospital support services and educational programs, as well as managing the Medicare Rural Hospital Flexibility Grant, Small Hospital Improvement Program, and several other grant programs on behalf of the Illinois Department of Public Health and other organizations. In addition, Pat is the Executive Director of the Illinois Rural Community Care Organization, which is a statewide rural accountable care organization comprised of 25 critical access hospitals and rural hospitals. Pat has more than 35 years of clinical and rural hospital administrative experience and currently serves as Secretary and will be President-elect in 2019 for the National Rural Health Association. She was awarded the Calico Rural Leadership Award by the National Rural Research Center in 2013, Rural Hero Award by the University of Illinois Rural Medical Education in 2016, and received the National Rural Health Association's President Award in April 2015. Pat serves on the board for the Healthcare Facilities Accreditation Program, the National Rural Health Resource Center Board, and Partners for Connected Illinois Board, and is a fellow member of the American College of Healthcare Executives, as well as a national speaker and facilitator. We're very lucky to have you here today. I'm going to turn it over to you, Pat.
Okay, thank you very kindly for the introduction, and always a pleasure to work with all of you and to work with the center. You do a great job in supporting our rural community hospitals and critical access small rural hospitals within our community. And, you know, we've been along this journey for a long time of how we can expand our programs into our rural communities, how we can engage them in new population and new delivery models. And I'm going to talk to you today about my experiences here in Illinois, working with the rural ACO, some of my other experiences in other areas, and try to share them with you. I don't pretend to be an expert, but I can certainly share all our lessons learned and help you through kind of the quagmire that's really out there today. You know, it's hard to know which way to go and all the new changes out there, and yet, you know, we have, you know, restrictions with payment models and, you know, just general changes that are going on with regulatory and other aspects of healthcare. So thank you for taking the time, and we'll go ahead and start, and let's see if I can get all my buttons to work here. So this is a pretty typical picture of rural Illinois, and you know, I probably can, most of you can identify with those pictures. I actually live in Princeton, Illinois, which is a town of about 8,000. It's about 2.5 hours south of Chicago, in a small rural community, and have been there for a number of years. So I can kind of speak on living in a rural community too. Today I want to share my experiences, as I mentioned, with our ACO and our new care delivery model, discuss some of the payment variances and care deliveries, why move to value-based care, talk about care coordination prevention, address some of the challenge of cultural change, and talk a little bit about the advantages, disadvantages, and really end with, you know, what is the true return on investment and why you would take that step forward. So let's go ahead and begin. I just have to give you the background so that you understand where my experiences come from. In 2014, we decided to, within the ICAN organization, several hospitals wanted to form a statewide ACO and adventure into the Medicare Shared Savings Program. We didn't really know what we were looking at that time, but we decided that this was a good step for us. And so we are in our second no-risk term with CMS, and looking at eventually moving into a program where we could handle risk in the future. We also have a contract with Blue Cross and Blue Shield in a shared savings model. So that just gives you a little background for where we are. This has just truly been our journey. You know, you don't just pull it all together. It takes time, and that's why I'm sharing my experiences may help you and maybe shorten some of the time that you would have to spend in putting together We were fortunate to get some of the AIM investment funds that came out for rural ACOs back in 2016, and so it really helped me expand the team that we have within ICANN that supports our hospitals. And we've been focusing on outcomes and building sustainability and all the things that are really important. And we've now gotten to the point where we're really taking one layer off at a time and drilling down to make change. And we think that we know a little bit more intricately what steps that need to take to really move the dial. So it's been a journey, I certainly can attest to that, but a good one. And a reason why you would want to embark in this type of a strategy is because we know rural hospitals, the closures continue, and these are pictures of many of the hospitals that have closed over time. I understand it's now 90 plus, and that's something that you don't know. But it drives us looking at why we need to change, why we need to look at delivery models, not just because of the Affordable Care Act that came out in 2010 that's moved us towards primary care, moved us towards new delivery models, but there's also other aspects that have built into it, such as the closures, the problems that we have with payment systems, and of course consumer health care impact. That world really has changed when I sit back and think about my career and, in what I've done, as a nurse and a hospital administrator and so forth over the years. There's been, tremendous changes. I remember when we only had 10% of our business with outpatient surgery and 90% was inpatient surgery, and all those things changed and the consumers really weren't involved. We had no smartphones. And so, we have to look at the impact that has on us. And, if we've been growing up in the other environment like I have, we have to think about that we have to change. We have to be ready for the future, and we can't have our heads in the sand. We also know that, the value-based care model has been really a plan of CMS for quite a while. It started in 2008. It's gradual buildup with getting and reporting your quality measures, and it's just been a steady increment. If you go on the CMS website, you can clearly see all the programs that they've put in place that really moves the dial. And I'm going to use the word dial a lot. Moves the dial closer to true value-based care. We still pay for procedures, but it's all going to be accountable for performance and impact on the quality of services. So with that, you can see, of the different programs, many of you may be participating in them, such as the hospital-acquired condition reduction program. And I was reading an article earlier this week about, remember the Institute of Medicine when they came out with the problems in healthcare, about, how we were doing damage to our patients and, all the quality effort that came. So really within the last decade or more, we have really made some tremendous strides. Doesn't seem like it, but we are making the move that way. And clearly, we have the, economic impact of hospital closures. We have the consumer interest. And of course, our government realizes the cost of healthcare and knows that value builds into it. They also know that there's been many, many studies out there that doesn't matter how much the healthcare costs, it doesn't necessarily guarantee value. So really the reason today is, are our rural hospitals ready for change? And this is actually a picture of Perry Memorial Hospital in Princeton, my hometown. Maybe you've seen the picture before, but I worked at that hospital for a number of years, and they are now a critical access hospital, and it's probably similar to maybe many of the hospitals that you work. So, yes, no, maybe, and really what's it going to take to be able to do this? So value-based care, as we've talked about, really focusing on the CMS definition. I know the Institute of Health has its definition and others do, but I really am going to, base it on, that they want to have providers have incentives for the quality of care they provide. There's very much a quality strategy and how healthcare is reformed. And, go back to Don Berwick, Dr. Berwick, with his triple aim, and I thought that was really a game changer for all of us because it really helped us to, yes, that makes sense, better care for individuals, better health for population, lower costs. So, it really, it drives the programs as we move forward today. Now, these are just a number of them that I pulled together. There probably are other demonstration models, but these are the ones that are most out in our communities today. Obviously, the accountable care organizations, the Medicare shared savings programs, patient-centered medical home, clinically integrated networks, comprehensive primary care plus, integrated health homes, Medicare Advantage, and I didn't pull up the end-stage renal diseases in those, but these are probably ones that would be mostly impacting your rural community hospitals. So let's start with accountable care organizations, which I probably know the most about and lived and breathed it for several years. And these definitions, and they may be a little bit boring to read it, but I do hope it provides a basis for you in your understanding. It's where groups of doctors, nurse practitioners, PAs, hospitals, and others come together and say, hey, we're going to coordinate care. We believe we can do it better by working together, and then we can contract with Medicare or other organizations in producing shared savings, return on the money we saved, or else going at risk where there's a greater return. It does require, the main element is coordinated care, because you have to make sure that you get people to the right place at the right time and duplication. And when it started in 2012, people thought, well, who the heck's ever going to get into this? I remember first reading about it, let alone to think that in 3 years later that ICANN and our hospitals were involved in it. And you can see that they've gradually grown over the years, and just to think that it's 12.4 million Medicare beneficiaries and growing every year. And what I like about the accountable care is really the focus on primary care services, and that's what rural health is all about, is our primary care. The next one is patient-centered medical home, and and it is a way that you as an organization can come together through your clinics and practice. It's not really so much hospital-based, even though the hospitals employ this practice within their clinics, but it's really, driven from the primary care field. And its objective is to bring all the providers together and to really, coordinate care. What I like about patient-centered medical home is that, we come from the hospital community. We have conditions of participation, regulations, for state hospital management and so forth. And it's a way of, it gives you guidelines for how you should effectively manage a physician practice or a clinic, or nurse-run clinic, or whatever it might be. But what it does, it helps you say, we're going to organize our care around the patient. What do we need? How can we as a practitioner be more efficient? How can we get the patient better care, more timely? And how can we better coordinate the patient's care through the system? It's really similar to the accountable care organization, that capacity. It just has a different framework. And, many of your contracts with commercial carriers will give you the increased reimbursement for your quality measures if you're successful for being accredited. And the compliance team, and I think the National Quality Organization, they are crediting bodies for this if you wanted to move that direction. And we have probably 10 of our hospitals in Illinois that have gone through and become certified patient-centered medical home. Okay, comprehensive primary care. This came out a couple of years ago, and it was a demonstration project for several states: Colorado, Kansas, Missouri, Louisiana. You can read them there. Many of you may have hospitals in those states that have practices that are participating in it. It was a way of incentivizing the practitioner to do the coordination of care from the primary care base, and to track the patient through specialty referral and so forth. And many providers have received $50,000 or more a year for providing care. And I can tell you the difference. We are in good partnership with Colorado, and they have instituted the CPC program in Colorado, where in Illinois we weren't eligible for the program. And I can see how their primary care practices are much better at quality, much better at coordination care than the hospitals that I'm dealing with in our practices. And I really think there's some advantage, and I really would like to see that expanded and developed more. But I think it's a good tool, and be aware that that's an option out there. And then there's the old global clinically integrated network, which really is kind of risen out of the Department of Justice, trying to come up a way that hospitals and providers can come together and coordinate care, and without violating antitrust and collusion and those kinds of things that would lead to difficulties within the the legal system. So they created a clinically integrated where you can come together as long as you had a common bond of duplicating services, preventing duplication of services, coordinating a patient through care, reducing medical errors, and so forth. And often they're physician-led or provider-led, and they have guidelines and clinical. So if you don't decide you want to participate in an ACO, you don't want to be a patient-centered medical home, you could participate in a clinically integrated network. There really aren't any restrictions on the number you can participate in because you're really working together with others as a group. Where, patient-centered medical home, that's a certification, a singular thing, where accountable care is a group and you can only participate in generally one of your primary care-based. So this is a broader and sometimes an easy way to move into the market. And you can contract with commercial carriers as a clinically integrated network. And potentially we're looking at, with Illinois, maybe building several clinically integrated networks together called a super clinically integrated network, and perhaps contracting with payers from a larger perspective. And of course, there's the Medicare Advantage programs that have been around since early 2000-ish, and where they actually have steerage in there that you promote health maintenance kinds of organizations where you're prevention and you try to keep people locally, and you have preferred provider organizations, and it's a way of reducing costs. There are some challenges with it because there's steerage there and trying to keep patients home within the network. You don't have the flexibility right now with Medicare, because traditional Medicare, you can go as a Medicare beneficiary anywhere you want to. Commercial carriers, obviously you're in network or out of network if you're a Blue Cross Blue Shield, Aetna, or whatever. With Medicare Advantage, it's a way that you can be a commercial product within traditional Medicare. It's presenting a challenges for critical access hospitals because they don't quite understand the real programs. They don't quite understand the critical access reimbursement, the cost-based reimbursement. And we know a number of states now, their commercial insurances for their employees, they've moved them into Medicare Advantage programs as they move to the Medicare eligibility later on. And so there's some trickiness with it, and we not sure quite how that will impact rural, but you need to be aware of these models out there. Global payments, and that's where a fixed prepayment is made to a group of providers. We know that in Maryland and Pennsylvania that they're experimenting with this. A group of hospitals are coming together. They're getting a cost payment. It's predictable. They don't have to wait for billing and all that they know they're going to get paid X number of dollars from the different payers alike. So it's something that we're seeing that the trend is, and I would say that bundle payment program, global payment programs where joint placement, where if you're getting a total knee or a total hip, that a hospital or the orthopedic practice gets one check for the care of the surgeon, the primary care practitioner, the hospital, skilled care, recovery, rehab, and so forth, is all in that one check. And so there are different methods of global payments. So we'll, we all know that it's been a little chaotic in DC these days, and haven't really talked much about healthcare. But when the conversation returns, we know that the Affordable Care Act that's in place, we know that there may be some changes made depending on who's in the administration. But we also know that there's no turning back. CMS has clearly said that healthcare, we've got to continue to grow it and look for new delivery models and so forth. We know that in the healthcare environment, people want to spend less and have better healthcare. We're looking for efficiencies and aligning suppliers and providers and so forth. And these are all just themes that I'm going to continue to bring back because they really are the emphasis of why we're moving to new payment models and why we have to be creative. We also know that the ACOs, whether you love them or like them, that they have saved Medicare billions of dollars over several years, and we expect that to continue. We also know that the CPC and patient-centered medical homes, when you map them out over a course of a couple of years where they've actually changed workflow and behavioral, that they are saving dollars and patients are getting better from that. So you as a hospital, why would a rural hospital, does our mission fit value-based care? Are we really a good fit for this, And I really am a big proponent of it because it's primary care based, and that's where we shine. Healthcare is local. Hospitals, and we also now either hospitals own or manage a vast majority of physician practices clinics in our rural areas. This was not common even 10 years ago. And gosh, no, 30 years ago when I was, in the heart of practice and with hospitals directly, that, physicians, they weren't owned by the hospital unless maybe you might be the radiologist, but now primary care is. And I don't see that changing at this point in time. So, we really are, whether we like it or not, in primary care. And so we need to figure out how we can be efficient and how can we influence the outcomes and how can it benefit us financially. We know the importance that regardless of which type of model you choose, that there's going to be the center around the patient. It's going to be primary care focused. And we have to help patients learn how to better use their health care. So strategies, so where do you begin? And this is where my experiences will come into play. As we know, it's the focus on the patient through the continuum. And I don't know why it got disjointed over the last number of years, or maybe it wasn't all that coordinated years ago and it's just heightened now. But we all thought the electronic medical records were going to be the end-all and be-all. They were going to fix all our problems. And unfortunately, it siloed us a little bit more because, you had to build interfaces, and not everybody had the same EMR, and so there were a lot of workarounds, and so consequently the patient really it got lost in that. And so we hurried up and get the patient to the next setting or the next level of care, and so we really haven't thought about the continuum. And that's why the push to primary care and push to these other delivery models, because it wants you to think about the patient through the whole continuum of care. It's like you belong to a medical provider, and they're going to see you from the beginning to the end, so to speak, like the old Dr. Marcus Welby. But and some of you may not even be familiar with that, but they all focus on wellness, Medicare well visits, or preventive care through the commercial carriers. They all focus on care coordination. And this is something where we're really struggling. We've learned that we have done a very poor job of managing care through skilled care. And that surprised me. I really didn't think that we had that. And you're going to hear me talk about it more. And that we really haven't been tracking specialty referral. We hurry up and a patient comes into the clinic and they need, some dermatology, or they have rheumatology, and maybe the primary care provider can't manage that, and or renal condition, and so they send the person to the specialist. And then you don't hear anything more. You never know what happens from there. And that's where the increased costs are coming into play, because we're not really managing it. And that's where the focus is on population health and how we're trying to tie this all together, and where the payers are coming from, and why it's important for you to pay attention. We're looking at improving medical diseases, the A1Cs and hypertension, and getting them under control, because now we can use our EMRs to track it and see how we do that. We can look at, in some of these programs, you're getting access to claims, and data is very, very powerful, and it helps us to reduce unavoidable ED visits and unnecessary admissions. So bottom line, having value-based care and having some of these strategies in place will help you with better utilization and save costs. And hopefully, in the end, it makes a difference for our viability. And I think one of the first things is really learning about your data. And I don't know how much you've done and how much training. We're going to start what we call Data Mania. We're going to do some lunch and learns for several weeks in a row to help break down, like, what do claims information tell you about your patients, where they're getting their care, what does quality data, your disease registries in your clinics. You can go in and you can ask for all my diabetics and find out what their A1C is. If your average A1C is 9 in your particular practice, well, that tells us, what are the strategies? Is it patient compliance? Is it the tools and the treatments that I'm ordering, readmission rates, and all sorts of things. And so old Dilbert, you have to, really look at getting accurate data and learning about that. And so what I'm going to try to do is show you some tools and how we've learned to use that. And if you're in an ACO, we have access to our claims. And this just shows you, if you look at here, and it's really all about the drill down. And here's, for an example, hospital inpatient cost. The average Medicare beneficiary in an ACO is like $3,800 a year in the average cost. And compared to this particular ACO or our ACO, compared to other ACOs, it's only $3,392, where fee-for-service is $3,726. So it begins to tell you, okay, my cost of inpatient care is a little bit higher. Is it because of the critical access? Is it I'm keeping my patients longer? And so you start to break down, what does that data tell you? Now here, particularly where your arrow is, the skilled nursing facility. So in our skilled nursing facility, the average cost is almost $1,900 compared to other ACOs at $700 or fee-for-service at $900. So what's going on? Is it swing bed tied in there, or is it our patients are staying too long in our skilled care? And what we've learned is not necessarily our skilled care, our swing beds, but it's our patients. In Illinois, our patients are staying longer in their skilled care at a higher cost than almost any other state in the country. So that's a way that we can use data to help improve. And so some of it we realized had to do with coordination of care. Another example, if you look down here, congestive heart failure or chronic pulmonary disease. We have a higher utilization of services compared to others. So what is it? Is it because they're going to the emergency department because they can't get into primary care? Are we not teaching our patients to better manage their asthma or COPD? So those are things that you use data to help improve the care that you deliver. Here's an example of the skilled care cost and how we drill down in looking at number of admissions and length of stay. And you can see our length of stay is 29 days compared to other 25 days. And, and our readmission rates and things. So it helps you to figure out where you begin to make changes. Here's another example from our claims data from CMS. We get a look at what our most common diagnoses is. And we seem to have a greater number of sepsis. Is it because of our nursing home patients? Is it a coding thing? Is it infections? Is it diabetes with complication? Are we higher than others? So that begins to help you figure out with your medical providers, where are the areas that you can make change? So if you're going to get into work with your providers and your payers are going to look at you, they have this access to same claims information, they're going to look at your hospital and say, oh, you have a higher incidence of diabetics returning to your emergency department, or your A1Cs are higher than others. Maybe I might not give you the best contract, or and that's why it's very important to look at your data and what kind of actionable steps can you take. So in our case, we have an average cost of $12,400 as an example. Let's take that as an example. So we looked at, you saw the data earlier where we had higher number of SNF days. We could improve the use of our emergency department. We have some chronic care with chronic obstructive lung disease. So if I would look at reducing SNF days and better utilization of ED, if I look at doing Medicare well visits, chronic care managed specialty training, then I look at this low-hanging fruit of how I can begin to reduce those dollars. And so that's how you look at it. Then you also look at, this is actually a report off of our Cerner program, where we can see leakage, that we know that a good portion of our patients is downstream spend. And so that's part of coordination of care. That's really specialty referral. We found out that when we initiated our push on managing specialty referral, very few of our practices and clinics had a tracking system in place when the patient left to go to a specialist or were transferred, that we got the patient back. And what did that specialist do for the patient? It was just kind of send them and get them there. I talked about disease registry and the tremendous value, and it's really underutilized, that your practices, if you're going to get into contracts, you're going to have to know about your diseases. What's the most common one and how are you treating? You know, what's the average blood pressure, hypertension in your practice? And so if you're getting into primary care, you're getting into how you can be a good player and potentially even taking out risk, because we have no way of controlling our risk now. And if you're going to get into some of these bundle payments and other things that rural hospitals are looking at, these are the things that you need to look at. So here's another example when you work with an ACO of patient engagement, measuring, you know, how involved are patients with our care. And they actually survey our patients. And these are things to find out that if you're going to move into those areas, how are your patients being involved? Do they, are they getting the care that they need? When many of our hospitals moved into having being certified as a patient-centered medical home, they started huddling. I mean, it seems simple. You're doing rounding in the hospitals, where they're doing huddling in the physician and clinic practices. And they're finding that, yes, we can squeeze this patient in today. They need to be seen. We can deal with this person. We can get a referral into play. We can begin chronic care management. So if they have those huddles, have those strategies in place, you become very successful at making a difference. So back to my original statement a few slides ago about data being powerful, it really does. It gives you the comparison of you and your peers. So if you are negotiating contracts, you can show how you've made improvements. Maybe you might not be the best in the West yet right now, but you could show trending about how you've brought care, you've improved your quality scores, and you've decreased your cost. And that's very, very important if you look at new delivery models, moving to risk, getting better contracts with payers. It is a must for us to be competitive. And we didn't really have that. Also, it gives you insight into your practitioner's performance, that, you know, it's not just how many patients you see today, but it's all in the quality and their performance. So what have we learned? You know, I've given you some examples and talked about the impact for us, and I can share with you things that we learned. It's very easy to talk it. It's harder to walk it, and I can tell you that change is hard and it takes time. I really thought that I could snap my fingers and we have all these great plans that people can put it in place, but you have the situation where somebody calls in sick that day at a clinic. They were going to start implementing strategies in patient-centered medical home. Somebody has a leave of absence for health reasons, or, you know, somebody's got transferred, and so the person that worked at the clinic, their spouse got transferred, and so they have to leave, and, you know, and you've got to fill the gap. So you have this new care coordinator, and boy, she's there, and I sure need her to manage that, to help with placing patients in the clinic or calling in scripts today. So, you know, gosh, we're going to have to put that care coordination on the back burner again. And that's some of the challenges that we went through early on, is understanding the reason for change and developing that sense of urgency. So I'm going to tell you, to begin with, it's not easy, and you have to get them engaged and involved. And but I believe we can do it better than anybody, because we don't have to go through 15 different layers to make change. It just requires commitment and using data to our advantage and understanding why the change is necessary. You know, here's a picture of one of our practices where, you know, it's just really it has to come change within. I can say you've got to have these 3 things in place tomorrow, and you might be able to put it in place, but will it stay? So it won't stay and it won't last unless the change comes within. And they have to understand the reason why. And for instance, so we've had trouble with trying to get callbacks. And so one of the hospitals finally said that, you know, in our physician practices, our medical assistants, our CMAs, have some time, and so they're going to do our callbacks. And once they started doing that, it was amazing the things that they learned. And what they did was they shifted something that the CMAs were doing that wasn't needed anymore in the clinic. They learned that doing the callbacks and making sure patients got scheduled for their next visit, or they found out did they get to their specialty referral, whatever it was, that made a difference, that they improved, and they actually rebuilt their business with that local clinic by just changing some of the workload and responsibilities. And it wasn't necessarily the physician had to change or the nurse practitioner or the PA had to change. It was just workflow changes. So, to really make long-standing change, they have to understand the cultural and the value, and it has to look at workflow. And we know that the full commitment has to come for the leadership. And many of you are involved with leadership, and you work with the CEOs, and you have to get them engaged, and the leadership has to come from the top. We know change comes from within, but we have to know that change comes, best handled when there's full support at the top and the change comes in. We know that moving forward with all the different types of value programs, that care coordination is a must. That's just really critical. And you have to figure out how to manage the downstream spend. I said that we manage probably 20% of our market. The one slide showed that we had about 30%. It just varies from place to place. But you have to be able to figure out what you can keep locally and what needs to send out. And then begin your strategy is how can you control that downstream spend? Because what happens in this episode of care that you only can do one MRI? Is it going to be done at your facility or only done at a referral center facility? And that could potentially impact our rural hospitals. If all of a sudden those MRIs aren't done there or those CAT scans aren't done because you only get one of them, so how are you going to manage that, and how are you going to try to rebuild it to make sure that things are handled at what you can possibly handle first? So tools to manage, we built what we call the playbook, and maybe this is helpful for you. And we're happy to share information and talk about that in the future if people want to have it. But we have kind of like a checklist each quarter that the hospitals, the person that's responsible within the ACO or whatever delivery program that you're in, checks, did they do well visits? Were there gaps of care done, like with Blue Cross and Blue Shield? Did they do their discharge follow-ups? What was their ER follow-up, referral? All these things, you have to have a way of tracking it on an ongoing basis so you can trend to see where this can lead. Some of our success stories is why, I was just looking at a couple of questions there, but better utilization of ED. And we found that a lot of it is unavoidable and is trying to figure out. One of the hospitals put in an urgent care center. Another ones, they've added the huddle feature every day to make sure that they get patients in that needed to be seen. And both of those institutions have reduced their unnecessary visits to their ED. And just by thinking about how we can better manage those frequent flyers, we also know that in Medicaid managed care organizations that there are cases where they are not paying for avoidable ED visits. So they call that the prudent layperson. So in other words, if a Medicaid patient showed up in their ED with a sore finger and they felt, well, that could be handled in urgent care, that visit may not be paid for. So if you work at other strategies to work with all your populations, you can deal with that. The care coordination with nursing homes, chronic care management, if you haven't started that, that's a whole webinar in itself about how you can move these patients with 2 or more chronic diseases in chronic care. You don't see immediate return in 6 months or even a year, but in 18 months, it's amazing. And we have medical providers saying to us saying that chronic care management programs that we didn't think it would work. We just didn't think that, because we were doing some callbacks and things like that. But when you have a concentrated program with chronic care management, you're actually billing for those services and tracking them, you are seeing substantial reduction within 18 months at the latest. Sometimes you see it at 12 months, but and you reduce those unnecessary calls. We have a health coaching program where we had a diabetic he had a 12 A1C, and by just doing a coaching program with him, within a matter of 3 months, it was down to a 7 A1C. So those are all things that you can do that are certainly strategies. Population health is really the crux of it, and it's kind of the buzzword that we all know, and that's a way, and it's really health prevention is when you're looking at how you can improve the care in your community, you're not only looking at your data of how you're providing care, through claims or your disease registries of people coming into your office, but you're also looking at the population yourself in your community, through home health services or health department. What are your community needs assessment? What did that trigger? What are the needs? Is it substance use disorders? Is it social issues? Are you seeing an increase of charity billing? Is there been an economic insult in your community that maybe you've lost of several businesses that have less people with insurance, difficulty to getting insurance? What are the things that we can do? What is your immunization rate? All these things tie into that global thing of population health. If we can keep our people healthy, then we have a better chance of improving the overall general health. But you have to think about when you're doing value-based care or you're doing contractors, they're going to look at how is the population in your community. You have an obese issue, and what are some of the strategies that you're doing to do that? So I've used this example a number of times, is that you look at your population. The first bracket on the left is generally how healthy people are and how you can work to keep them healthy, getting well visits and screening, and that's about 50% of the population, whether you're under 65 or over 65. Then the rest of the 50% is divided into people with early onset to try to trigger with diabetes, keep that under control, medication abuse. Full onset is people with multiple conditions. They're in and out of your emergency department, and so you're building chronic care management programs. And then complex diseases is how are you vetting people for specialty care? Are there referral centers? If you have breast cancer, are they getting to the most the center within their driving distance? Maybe there's several of them, and you're able to determine one with the best outcomes, one with the best cost efficiencies there. And so you're looking at, when you're looking at your population and trying to look at how you make improvements, thinking of your healthy people, what are you doing for them? Your strategies for early onset, strategies for full chronic and complex care. What are your resources and specialty referral? And last, along that same line is social determinants. I happened to be watching New Amsterdam last night on TV, and it was interesting. The physician gave the homeless person a script for an apartment, and I know that's been talked about in the literature, and in a number of hospitals, particularly in inner city, have done that because of the homeless. And so we've had to look at what are the social determinants, and it does make an impact. And if you were going to have global payments and be responsible for a group of patients, you have to think about what are the other things for that. Do they have mental health services and so forth? And obviously prevention, and our hospitals have done a number of different things about outreach and screening programs and so forth, especially for stroke. Do you have a system in place? Is your hospital emergency stroke ready? In the fact that you're getting patients that have onset of stroke to the hospital as quickly as possible. We all know that the hub of the community is the hospital and rural communities, and your top 3 employers. You own mostly all your physician practices anymore. Most of your hospitals have 3 clinics, rural health clinics. You may own the ambulance, or you're at least supporting the ambulance in some capacity. And really, anymore, it's very hard to get a medical provider to live in a community without access to a hospital. And you have to have the support systems of the pharmacy. So you really have the ingredients to build your own integrated community, and that's where you can build in your value-based care. So what's the return on investment that I can offer, and we can get into some of the questions, is increased patient satisfaction scores. Those are the hospitals that have embraced it, that are really looking at your quality. Whether you like the quality scores or not, or the measures, it's how the rest of the world is seeing us. So I'd much rather be viewing in the upper percentile and so when you make efforts to improve your patient satisfaction scores, to improve your quality scores, it does pay off, and that does get people returning your facility. They look at you, boy, they've got good quality scores, or they've got the patients And when you are coordinating the patient's care, that does improve their satisfaction. Chronic care management, we are reducing those frantic calls. We are seeing decrease in ED, unnecessary visits, through better utilization. We are seeing those that are embracing these things, they are getting their primary care back. They are seeing increased volumes. And that's what you worry. You think, well, gosh, if I reduce ED visits, what's that going to do to my bottom line? The bottom line is that you're getting paid more appropriately. You're getting those patients to urgent care. You're getting new services that maybe you didn't have before. And so there is that ROI if you really map through it. You don't have to continue to look at your hospital. Where am I going to cut? That was the emphasis that we had maybe 5 years ago, before we started looking at regaining primary care for rural hospitals, is cut. Well, let's look at the types of service we're providing and rebuild our primary care market. Maybe you've done a good job, but it's been a challenge, at least I know in Illinois, to regain some of our market share. So some of the disadvantages, obviously, it's hard to change culture and workflow, cost, time commitment, and how do you go at risk if your hospitals have a margin of maybe 1%? Physicians get frustrated, nurses get frustrated, staff not buying in. And we found that making change, like with patient-centered medical home early on, it wasn't the medical providers embracing these ideas. It was getting the staff around, because they were used to, their workflow went one way, and that was what they were used to. And that takes time to see the value. And obviously the advantage is you learn best practices, you keep your patients locally, you have healthier populations, your contracts, you're ready for the change that we know that CMS has mapped all this value-based care and these programs out to 2045. So you don't think that this isn't going to happen. It is. And it really lends you for being stronger financially in the long term, and obviously you have good patient outcomes. It doesn't happen automatically. It takes time. So in just kind of summary, healthcare is locally. You do need these strategies. I've tried to outline some of the things that we found that have been successful. We've worked hard to try to manage our primary care, but and then we work with our systems to better manage specialty care. And how do we blend that and keep that where the flow of communication? So this is just an example that we believe that the rural hospital is the community, and how we work together, and the communication, it becomes a positive communication. Because when it's all said and done, and you'll see me if you heard me speak a number of times, is that when you do all these things all said and done, our business is still about the patient. And so we put them in the center. What can we do to better coordinate, to save them dollars and cents, to improve the services with their primary care provider? Can we rearrange our workflow to make a difference? And I hope I shared some of our experience, shared some of the tools that we've used, and some of the claims information that we've learned about our patients that lends us to discussion. And I'm happy to open up the calls and take some questions, and hopefully provide some information that was helpful to you. I can see some questions there. So Kim, I'm going to turn that back to you, and you tell me what you want me to cover. So.
Great. Thank you so much, Pat. That was an excellent presentation with so much detailed information and great tools that you shared. I know that Blake and Kimberly had a few questions earlier on. Blake and Kimberly, are you on the phone line? If you are, press *2 to unmute your phone line, and you can go ahead and ask the question yourself. And if not, I can just read Kimberly's first question. You actually answered it, Pat, later on the call, but she said more detail is welcome. So Kimberly's question was about how you identified reasons their skilled care costs were higher than national averages.
Well, I'll tell you, I was blown away. I never saw that, but when we actually got data from, and you can go probably on the website of CMS, but it gives you all the skilled facilities, and it tells what their average length of stay and their costs are. And so we were able to do that comparison and see where we ranked. And then we learned as our skilled nursing facilities tied to our ACO, we found that we were in the bottom 5% of that, and I had no clue. So we were using national averages, and this information has not been readily available. It's just now been available in the last year or so. If you would like some help, then please let me know, and I'm happy to steer you in the right direction if you would like to gather that information. But it is out there. It does take a little time to kind of figure it out and to learn from it. But all the skilled nursing facilities are mapped out. The swing beds are not included in that. It's your skilled nursing facility, because I think they take their tax ID numbers and map them out so you can see their average cost, their star ratings, and so forth. And it's just been up the last year or so that information has been available. And our data goes back to 2016, and we should be getting the 2017 data later this year.
Thanks, Pat. To what extent are rural health systems being made aware of global marketplace? It sounds like ACO is a topic that has some traction, but what are your thoughts about the global marketplace?
Well, I think the reason that there hasn't been a lot of attention like it has for the ACO, because ACOs are pretty, groups can come together, where global markets you would need to have a number of, so that you had, with the ACOs you only had to have 5,000 beneficiaries. With the global markets, I think you're going to have, tens of thousands available for that. And you generally have to involve the state to make changes in how you set up your payments with insurances and Medicaid and Medicare. So it requires a statewide effort. Where an ACO or clinically integrated, you can do the work within that set group and form a legal entity. So there's a little bit of differences through that you can you can find that out. And also they're really in early stages of that, with Maryland and Pennsylvania starting their year, and Maryland has about a year. So it's just early. But I think you can look at, if you're wanting to know more about it, episodic payments such as the total joints that CMS pushed a couple of years ago. They were getting pretty good traction with that, and I see that may be coming back. They're voluntary participation, but if it's another way that people might be able to earn some additional dollars, if you're the orthopedic surgeon and you wanted to be able to do total needs, if you make arrangements with hospitals and skilled facilities for managing the patients or home health and discharging them, you have a chance to gain some additional dollars to your bottom line. And so that's an example of a short term, and that's easier to participate. But it's because the ACOs and the clinically integrated are easy to participate than the global, because it involves more of a statewide. I think that's why the attention started there first.
Thank you, Pat. And actually, next week, Dr. Clint McKinney will be touching a little bit more on global budgets and the global marketplace in his webinar presentation. He's also on today's webinar. Clint, if you are called in, and you can press *2 to unmute if you want to say anything more about that. Otherwise, Blake also has a question, Pat. His question: we have brought multiple offers for value-based approaches to patient care to payers. The payer, commercial or Medicare Advantage, typically claims that we do not have enough covered lives for it to be worth their time to administer such a program for such a small group. How do you suggest dealing with payer disinterest?
Well, it depends on, what your group is what kind of a group. We had to pull together several of our hospitals in a group together. It's because if you're going to take risk, it has to spread over so many lives, as you know, even being statistically relevant. I think if the best way to deal with payers is, maybe if you can't pull a group together, is to take the common practices and principles that you see in some of these ACOs or value-based care programs, such as you have care coordination guidelines in place, or you have utilization management in place, you have medical providers to do reviews and things like that. If you have some of those practices in place, you may be able to get some attention, at least when you're doing contract. But you may require somebody to take that leap of faith and pull a group together and maybe form a clinically integrated, and then you can begin some conversation with commercial carriers. There are some insurance companies, some regional brokers that may be interested in partnering with a number of group of hospitals, and that they would take the risk and develop self-funded programs that they could market to their employers. That's another way that I really didn't cover very much, but that's certainly another way that you might be able to do that. And I'm happy to talk to you off the line too if you would like to talk a little bit more about strategies.
Actually, yes, I would.
Okay, sure. Do you have my email? You know, just send me an email, or Kim,
What's
you
your
can
email
send.
address?
It's
Pat,
go ahead, Kim.
go ahead. Oh, I was just going to say Pat's contact information can be found at the last slides of her PowerPoint presentation, but I can also put it here in the chat box.
Oh, thank you very much.
Sure, happy to. It sometimes gets a little complicated because there's several different ways that you go at it, and maybe we can talk about your situation. I might be able to be a little more helpful than just my general comments.
Great, thank you so much, Pat. And thank you, Blake, for your question, and Kimberly for your question. If anyone else has any questions today, you can press *2 to unmute your line or put it into the chat box. Clint, are you on the line?
I am on the line. Thanks very much, Kim. And thank you, Pat.
So everyone, Dr. Clint McKinney will be speaking next week, and he's going to be speaking specifically to physician engagement for value-based care and success. And he's also going to touch on some of that quality payment program updates that are happening. Do you want to talk a little bit about that, Clint?
Oh, no, actually, I think, Kim, you did a good job. I'm going to talk a bit about the importance of physician engagement in value-based care programs. That's the first, and then if we do have time, a little bit of an update around the quality payment program. Also, I am doing some pretty extensive work in Pennsylvania with their global budget, and that's a hospital global budget model. So